Welcome to my lecture on gallbladder and bile ducts. As this subject is a very wide subject, to make it easier to present and easier for you to understand, I have made it into 4 parts. In part 1, I shall be discussing the surgical anatomy, physiology, and imaging methods employed in gallbladder and bile ducts. This slide illustrates the outline of the gallbladder and bile ducts. Okay, the area that we are discussing is shaded in green. This is the gallbladder, which consists of the fundus, the body, and the neck, which is then connected to a cystic duct, which drains into the bile ducts. The bile ducts consist of intrahepatic and extrahepatic ducts. The ducts form in the liver as the intrahepatic ducts and leaves the liver as the right and left hepatic ducts. These will join at the hilum of the liver to form the common hepatic duct. This common hepatic duct, after receiving the cystic duct from the gallbladder, is known as the common bile duct or CBD. Okay, common bile duct. This common bile duct will then continue downwards and to the right to carry the bile from the liver into the second part of the duodenum where digestion takes place. Okay, this is an important diagram, okay, to show you the location of the surface anatomy of the gallbladder on the patient. Okay, there are few landmarks that must be considered. First is that it is located in the right hypochondrium, right subcostal margin here. Then it is also at the transpyloric plane, which is indicated by this red line here, which runs through the pylorus of the stomach at the lower border of L1 vertebra. The third one I find it very useful to identify in patients is the mid-clavicular line. A line drawn from the midpoint of the clavicle perpendicularly runs down, and where it meets the costal margin, right costal margin, is where the gallbladder is located. And the other last landmark is the angle between the right costal margin and the lateral margin or lateral border of the rectus abdominis muscle. So these are the 4 landmarks that will help to locate the gallbladder on the patient. Normally, the gallbladder in adults is not palpable. If it is palpable, it is abnormal. In babies and young children, at times it may be palpable normally. The next anatomy is of surgical importance is the Kellogg's triangle, okay, which is the grey shaded area in this diagram here. Okay, it has got a lateral boundary, the gallbladder and the cystic duct. The medial boundary is a common hepatic duct and at times the right hepatic duct. And the superior border is the inferior surface of the liver. Why is it important? The contents of the Kellogg's triangle are very important to the operating surgeon. The 3 main things are the right hepatic artery and its branch, the cystic artery. Okay, this cystic artery has to be ligated in the and transected in patients during cholecystectomy. So this is a very important landmark for the surgeon. And the third content is the lymph node of Lund, cystic lymph node of Lund, which is located in the center of this triangle, which drains the gallbladder. Okay, the cystic duct is another small structure. It's about 3 centimeters long. Okay, which drains the gallbladder contents into the bile ducts. Okay, so this is a very small duct, 3 centimeters long, 1 to 3 millimeters in diameter. The wall of the thickness of the wall. In the vast majority of patients, it joins the hepatic common hepatic duct to form the common bile duct. And this junction is above the, usually located above the common duodenum. But in small number of patients, this junction can be anywhere between the common hepatic duct right until the lower end of the CPD. And this, as I say, is a very important duct that must be ligated and transected with great care during cholecystectomy, either open or laparoscopically. Now we come to another important structure, very small, it may be a very small structure but very important to the surgeon. That is the common bile duct or the CBD. The CBD is formed by the cystic duct joining the common hepatic duct above the duodenum in most cases. Okay, it is about 7.5 centimeters long and about 6 millimeters in diameter. It consists of 4 parts. First, as labeled here, the first part is the supraduodenal part, which is around 2.5 centimeters long, and it runs along the lesser free edge of the lesser omentum. Then the second part is known as the retroduodenal part, which runs behind the first part of the duodenum. The third part is the infraduodenal part, or some people call it the retro or the pancreatic part, which runs through the posterior surface of the pancreas. And the last part, the fourth part, is the intraduodenal or transduodenal part, which is in the wall of the duodenum. It's a very short segment. Okay, it opens in the second part of the duodenum, surrounded by the sphincter of body. Okay, and what is this sphincter of body? The sphincter of body is the smooth muscle that guards the tip of the ampulla of water. Okay, this is a close-up view of the ampulla of water and the sphincter of body. The ampulla of water is formed by the common bile duct and the pancreatic duct. They join to form the ampulla of water, which pierces the wall of the duodenum and enter into the lumen at the summit known as the papilla. And this summit is guarded by a sphincter known as the sphincter of body, which is a thickening of the circular muscles of the wall. And this takes place in the wall of the second part of the duodenum. So the sphincter of body is a muscle which acts as a valve to keep the flow of bile and digestive juices unidirectional from the ducts into the lumen of the small intestine and prevents the reflux of duodenal contents back into the ampulla. What is this important? This is a very important because these days Ercp, which is a very important procedure, is done by injecting the dye into this ampulla of water through a duodenoscope. And sphincterotomy is also done here to remove stones which are commonly impacted in the lower end of the ampulla of water. To the blood supply of the gallbladder. The gallbladder predominantly receives blood supply from the cystic artery, and this cystic artery comes from the right hepatic duct at the middle of the Kellogg's triangle. This right hepatic duct artery in turn comes from the common hepatic artery, the celiac trunk, and finally it originates from the abdominal aorta. In a small percentage of patients, the accessory branch also given from the gastroduodenal artery, which also supplies the gallbladder. This is important to recognize this artery, otherwise it may cause troublesome bleeding during cholecystectomy. the lymphatic drainage and the nerve innervation of the gallbladder and the biliary ducts. Okay, the gallbladder is drained by the lymphatics, which enter into the region of the callous triangle, into the cystic node of Lund, which from there drain into the hilar lymph nodes at the hilum of the liver, and from here it drains into the celiac lymph nodes. Okay, celiac lymph nodes, which then enters into the parietic lymph nodes. So the direction of flow is on the gallbladder, to the hilar region, and then to the celiac plexus. The nerve supply is mainly from the parasympathetic and the sympathetic. The parasympathetic from the vagus maintain the tone and contractility of the bile duct and the biliary ducts, whereas the afferent sympathetic fibers mediate the pain from the gallbladder and the bile ducts. So sympathetic system for contractility and tone of the gallbladder and the bile ducts, whereas sympathetic is for the pain from these areas. Next, we come to the physiology aspects of gallbladder and biliary disease. At the liver, the bile is produced, and the bile that's produced contains 97% of water and 1 to 2% of other things like bile salts, pigments, cholesterol, calcium, and fatty acids. The excretion of the bile from the liver is at the rate of 40 mL per hour, which works out to be about 1 liter for 24 hours. Gallbladder, the three main functions take place. First, it is the reservoir for bile, especially during fasting, where bile is stored in the gallbladder to be released after meals. Second, concentration of bile takes place in the gallbladder to about 5 to 10 times the original concentration, and this is done by the active absorption of water. The third function is mucin secretion, which is around 20 mL per hour. The vagus and cholecystokinin (CCK) cause gallbladder contraction, simultaneously relaxation of the sphincter of body. So by this synchronous action of the gallbladder contraction and sphincter of body relaxation, bile is excreted into the duodenum. Now we come to the bilirubin metabolism, which is a very important pathway to understand in patients with biliary disease. Okay, it takes place in 3 phases or in 3 media. The first medium is the blood, okay, and this is known as the prehepatic phase. In the blood, what happens? Unconjugated bilirubin is generated, and this is from the hemolysis of the RBC, which take place in the reticuloendothelial system, in particular spleen. Unconjugated bilirubin, which is released, being non-water soluble, has to be conjugated or complexed with the albumin to be carried to the liver, where it enters the liver or hepatic sinusoids and then into the liver cells or the hepatocytes, where it is conjugated with glucuronic acid to conjugated bilirubin. Okay, and this is the intrahepatic phase, okay, or the second phase of the metabolism. This conjugated bilirubin is water soluble and is excreted into the bile ducts, which carry the conjugated bilirubin to the small intestine, that is the second part of the duodenum. Okay, and in the third phase, which is the small intestine, which is known as also the posthepatic phase, This conjugated bilirubin that reaches the small intestine is acted upon by the bacteria to convert it to urobilinogen. And a large amount or large proportion of this urobilinogen is then converted to stercobilinogen and excreted in the feces. Stercobilinogen gives the normal brownish color to stools. A significant percentage, 10 to 20% of this urobilinogen enters into the enterohepatic circulation between the small intestine and the liver, whereby the urobilinogen is recycled for further use. A small quantity diffuses back into the circulatory system to the first medium, where it is then taken up by the kidney and excreted in the urine as urobilinogen. So in the prehepatic phase, that is the blood, unconjugated bilirubin is released. In the liver or intrahepatic phase, this is converted to conjugated bilirubin, and in the intestine, it is converted, or the posthepatic phase, it is converted to stercobilinogen, and also the enterohepatic circulation takes place. Next, we come to the imaging of the gallbladder and the bile ducts. Imaging of the gallbladder and the bile ducts. This consists of a number of methods that can be used today. The plain X-ray abdomen is the oldest investigation. The ultrasonography or the ultrasound scan, which has become the most important first-line investigation for these cases. Computerized tomogram or the CT scan, especially useful as an addition to this ultrasound, especially when you're thinking of soft tissue lesions of the pancreas and the liver. Next is the magnetic resonance cholangiopancreatography, which is an MRI investigation, also in short known as MRCP, which is a good method to identify the biliary ducts. Then the endoscopic retrograde cholangiopancreaticogram, or in short ERCP, which is a radiological investigation, and it has become a very important investigation these days. And the last is endoscopic ultrasound, EUS, which also can be used to biopsy lesions near the lower end of the bile ducts. The others I mentioned here are of less importance these days, okay, which are not often used today, but the most important among them is the HIDA scan or the hepatobiliary immunoacidic acid scan, which is a radioisotope scan of the gallbladder and the bile ducts, which is usually very useful in children. Okay, this is a plain X-ray abdomen showing you the uses in gallbladder and biliary ducts. Okay, for gallstone itself, it's only 10% of gallstones are radio opaque. Okay, for example, in this first slide here, it shows you a gallbladder filled with gallstones. Okay, and these stones on plain X-ray are only 10% of them are visualized because most of the gallstones are radiolucent. 90% of them are radiolucent. The case of a porcelain gallbladder is a chronic cholecystitis with calcification, massive calcification of the gallbladder, which can be easily seen on a plain X-ray. Okay, and this porcelain gallbladder is considered one of the predisposing or pre-malignant conditions of carcinoma of the gallbladder. The third condition that is useful by doing a plain X-ray is the finding of gas or air in the biliary tree, and this is known as aerobilia. Once you find aerobilia, then it is something abnormal. In the past, it used to be due to severe Clostridium infection causing severe cholangitis. But these days, these infections have become less common, and more commonly is due to manipulation due to Ercp. Okay, so these are the more common causes today. So these are the three in situations in which the plain X-ray of the abdomen may be useful. Next we come to the ultrasonography or USJ. Okay, now ultrasound has become the most important initial imaging method. Okay, because of the following favorable conditions: safe, painless, accurate, convenient, cost-effective, and readily available in many centers. It easily detects gallstones, gallbladder, thickness of wall of the gallbladder, whether it is inflamed, and the surrounding inflammation. It also detects, in some cases, biliary stones. It can measure the size of the ducts. Okay, and sometimes it can be used to detect common bile duct stones and growth in the pancreas, adjacent pancreas. This is an ultrasound picture, normal gallbladder. You see the gallbladder here, pear shape, the neck and the fundus. There's no opacity within the gallbladder. The gallbladder wall is thickened and you can see it's smooth. Compared to this is a gallbladder. Okay, enlarged view, multiple stones here. The opacities here, these are the multiple gallstones. Hyperechoic shadows here. And how you know these are gallstones? Because gallstones cast a posterior hypoacoustic shadow. Okay, other tissues do not produce these shadows. Then it also measures the gallbladder, thickness of the wall here. There you can see thickened, and then the wall of the gallbladder is edematous with edema fluid. This is a ultrasound picture of a gallbladder that is acutely inflamed, acute cholecystitis. The next is CT scan and MRI scans. Okay, CT scan is very useful for detecting liver and pancreatic lesions, especially mass lesions and tumors of the pancreas and liver. It is also very useful in the staging of liver and pancreatic cancers and also bile duct cancers. It can also give you the size enlarged lymph nodes, detect presence of enlarged lymph nodes. But the disadvantage is for gallstones, it's only 75% of them seen on CT scan. Therefore, it is not good for screening. In fact, ultrasound is better for screening because it detects more than 95%. The detection rate is more than 95% depending on the experience of the radiologist. The next is the magnetic resonance or MRI of the gallbladder and the bile ducts. Okay, this is useful imaging for the gallbladder and the bile ducts. It gives you any lesions within this lumen of these ducts. It outlines the ducts very well. It can show bile duct obstruction, strictures, and other intraductal abnormalities like cancers. The drawback of this method is that it is solely diagnostic. It is not therapeutic. Okay, and the last one I want to go through is a ERCP. Okay, the ERCP is a procedure where a scope is passed through the mouth of the patient. Okay, this is a duodenoscope, and the scope reaches the second part of the duodenum here. Okay, and the tip of the scope has got a side viewing camera as well as a passage for passing in a catheter. Okay, so a catheter is passed through here, as can be seen here, and it used to cannulate the papilla. Okay, and inject the dye into the ampulla of water, and this dye is then used to take pictures of the biliary and pancreatic system. Okay, this is a nice smooth pancreatic biliary duct with intrahepatic ducts here. This is the cystic duct and the gallbladder. And here at the lower end, the pancreatic duct, which joins the common bile duct to form the ampulla vaulter. Okay, this is a very good investigation, not only for diagnosis, but it's also used for therapeutic purposes, where you can do a sphincterotomy and remove the stone in the lower end of the CBD. You can insert stents and also dilatation of the bile ducts. The only setback is it is done under heavy sedation, and as minimum is a day case. Sometimes need to be admitted. So this is the only drawback. Otherwise, it's a very good procedure. Okay, it is a mini invasive procedure. Otherwise, it is very, very favorable. Next, we come to part 2, the gallstone disease. Okay. Gallstone disease, also known as cholelithiasis. Okay, and it's a very common disease. It's 10 to 15% of adults have gallstones, and 80% of them are asymptomatic. And every year, about 1 to 2% of these asymptomatic cases develop symptoms which require some form of treatment or surgery. The female to male ratio is 4:1. Okay. Under the etiology, we have a number of predisposing factors. The classical teaching of fat, fertile, flatulent, female, 40, and family history. And the 6 Fs are very important. It's still very true till today. As far as the predisposing factors, there are a number of factors. One is affecting the gallbladder itself. That is impaired gallbladder function, either emptying, absorption, or excretion. The second group of factors is the cholesterol nucleating factors, which result in the cholesterol becoming crystallized in the gallbladder. And this is related to the mucus, glycoprotein, and infection of the gallbladder. Next is supersaturated bile. In the bile that is formed in the liver and secreted into the bile ducts are supersaturated and with some certain components in the bile. And these are related to the age, sex, genetics, obesity, and diet. Okay. And the last factor is related to factors, reabsorption, factors in the small intestine which affect the absorption and the enterohepatic circulation of the bile acids. These are the deoxycholates, bowel transit time, fecal enteroflora, ileal resection, and the drug cholecystomy. Okay, these are the 4 groups of predisposing factors that predispose one to form gallstones. Okay, now we come to the formation of stones. Okay, bile salt and lecithin are very important. Bile salt and lecithin are very important to keep cholesterol in solution. Okay, when the stability between these 3 elements are lost, then excessive cholesterol, there may be excessive cholesterol or maybe reduction in the bile acids and reduced lecithin. So these factors, when the stability is lost between these 3 components, gallstones tend to form. This is clearly demonstrated in this graph here. The bluish or blue shaded area is the area where the cholesterol is in solution, so no stones form. Whereas the larger area, red in color, is the region known as the lithogenic prime, where cholesterol tend to form. And this is dependent on the cholesterol percentage of lecithin, and percentage of bile salt. So as I said, to keep cholesterol in solution in this safe blue area, you need decrease cholesterol, increase bile salt, and increase lecithin. So the cholesterol, when this percentage of the components stability is lost, the cholesterol goes into the red area, which is known as lithogenic bile. There are three types of three types of gallstones: cholesterol stone, pigment stone, and mixed stones. Cholesterol stones are seen here. Contains almost up to 99% of pure cholesterol, and this results in the supersaturation of the bile with cholesterol. The stones are usually large in color, yellowish, and their number is usually a few or single. Pigment stones generally have less than 30% cholesterol, and these can be divided into black pigment stones and brown pigment stones. Okay. The black pigment stones are usually associated with hemolysis, such as hereditary spherocytosis, sickle cell disease, thalassemia, and G6PD, and at times liver cirrhosis. Okay. These hemolytic diseases predispose to the formation of black pigment stones. Whereas brown pigment stones are rare in the gallbladder but form in the bile duct. Okay. So I said 90% of stones formed in the gallbladder, and 10% formed in the bile ducts. Okay. So these stones, brown pigment stones, are rarely formed in the gallbladder. They form more primarily in the bile ducts, and they are related to bile stasis and infection of the bile. Okay. Predisposing factors: bile stasis and infection of the bile. Also associated with foreign bodies within the bile ducts, example, endoprosthesis. Okay. The placement of prosthesis in the bile ducts in Ercp predisposes the formation of brown pigment stones. Now, what are the complications of gallstones? Okay, look at this chart. Table, the picture here shows you the gallbladder with a stone. As I said, 90% of the time the stone is formed in the gallbladder, and also the bile ducts here. Okay, there are also stones in the bile duct. These are the four common complications of gallstone. The stone here sometimes cause irritation and obstruction of the cystic duct. As a result, there is colic, that is biliary colic. It can cause erosions of the mucosa, ulceration of the mucosa of the gallbladder, and inflammation. At the same time, it can also cause bacterial infection, and that is acute cholecystitis. Chronic attacks of acute cholecystitis can lead to chronic cholecystitis, and stones, okay, obstructing the lower end of the ampulla region causes obstruction of the pancreatic duct and initiates acute pancreatitis. Mucocele gallbladder, empyema gallbladder, and perforation are all complications of gallstone, especially acute cholecystitis. Obstructive jaundice, acute cholangitis, and liver abscess are complications of stones in the CBD or choledocholithiasis. Stones in the CBD can give rise to obstructive jaundice, cholangitis, and liver abscess. And these last three are not so common: Mirizi syndrome, intestinal obstruction of gallstone ileus, and carcinoma of the gallbladder. Next, we come to the third part of the lecture, which is common diseases of the gallbladder and bile ducts. Diseases of the biliary system. First, I'll go through generally what are the diseases common diseases of the gallbladder and the bile duct. Okay, the gallbladder, the first four in green are the most common conditions. Cholangitis or gallbladder stone or gallstone disease, biliary colic, okay, acute cholecystitis, chronic cholecystitis. The next, empyema, gangrene and perforation are complications of gallbladder or gallstone disease, especially acute cholecystitis. Next will be gallbladder polyps and carcinoma of the gallbladder, which are much rarer conditions. So the most common conditions are all related to gallstone disease or cholelithiasis, which I have discussed. Under the biliary ducts, diseases of the biliary ducts, you have cholelithiasis or CBD stone and its complication, cholangitis, stricture of the bile duct. These are the three most common causes of biliary diseases of the biliary ducts. Others include congenital conditions like biliary atresia and choledochal cysts, which are seen more in children. Then inflammatory conditions like sclerosing cholangitis, which is also a pre-malignant or predisposing condition to Cholangiocarcinoma. And then you've got the three malignant lesions, which are causes of obstruction of the CBD and obstructive jaundice. These are known as the triple cancers of the bile duct. They are carcinoma ahead of the pancreas, Cholangiocarcinoma, and Peri-Employee Carcinoma. Okay, first I shall deal with symptoms and signs of biliary disease. First, the symptoms. Okay, you can classify them into specific and non-specific. Among the specific symptoms are this: pain is the most common symptom of gallbladder and biliary disease. Okay, the pain is usually sudden in onset, occurs mainly localized to the right hypochondrium, and can radiate to the back or the right shoulder. Typically, the pain is aggravated or precipitated by food rich in fats, and sometimes the patient also complains of breathlessness when the pain comes, due to when the patient takes a deep breath, the inflamed gallbladder rub against the causes pain, and so the patient stops breathing. Next, the onset is usually acute in a couple of days, 1 or 2 days, maybe within a week or two. So that is acute onset, the pain comes in. Other symptoms include jaundice, yellowness of the skin, tea-colored urine. These are other complications, other symptoms. Then can also have pruritus due to obstructive jaundice, and clay-colored stools also due to obstructive jaundice. The non-specific symptoms are these: nausea and vomiting, fever, loss of appetite, diarrhea, lethargy, and feeling generally unwell. Okay, these are called non-specific because it occurs in most abdominal conditions, not specific for the gallbladder and biliary diseases. Next becomes the signs of biliary disease. Okay, these are the signs commonly seen in gallbladder and biliary disease: jaundice, okay, fever, and the fever, if it is associated with bacterial infection, can be classically with chills and rigors. Okay, very important to get fever with chills and rigors. Tenderness and guarding with rebound tenderness, localized more to the right hypochondrium and sometimes extending to the epigastric region. Murphy sign may be positive, which is the stoppage of inspiration and pressure is applied in the right hypochondrium. and this is due to an inflamed gallbladder. Palpable gallbladder, this is especially so in lesions, malignant lesions obstructing bile duct and causing obstructive jaundice, a palpable gallbladder, and hepatomegaly, enlarged liver. Okay, also seen in obstructed bile duct. There are three things that you must be familiar with. One is the Charcot's triad, which is 3: pain, fever, and jaundice. And this is the classical features of ascending cholangitis. Then you have Raynaud's pentat. In addition to Charcot's triad, there's hypotension and mental status, mental derangement. And this may be due to secondary infection of an obstructed bile duct, leading to gram-negative septicemia. And the third one is your Govacius Law, which states that in a jaundice patient, obstructive jaundice patient, if the gallbladder is palpable, the cause is unlikely to be due to gallstone obstruction of the CBD. On the other hand, it is more likely to be caused by more sinister conditions, carcinoma head of pancreas, Cholangiocarcinoma, Peri-Employee Carcinoma. Okay, next we come to the most common disease of the gallbladder, that is the acute cholecystitis. Okay, and biliary colic, we can classify them together because their symptoms are similar. Okay, acute cholecystitis is a very common surgical problem that you see in the wards. Okay, and it's mostly associated with gallstones. 95% of the stone in the gallbladder in the patients with acute cholecystitis is impacted in the Hartmann's pouch or the cystic duct. As I mentioned, there are 3 types of stones, and the most common is mixed stones. Bacterial infection of an obstructed gallbladder is a common complication, which is usually due to infection by gram-negative aerobes such as Escherichia coli, Klebsiella, and Streptococcus faecalis. These are gram-negative aerobes. At times, in severe cases, it can also be infection with anaerobic infections, such as Bacteroides and Clostridia. And that is the reason you have to know that it causes, what are the bacteria that causes this infection, so as you can institute the proper antibiotics. And normally the antibiotics given is cephalosporin with metronidazole. It's very important to understand the pathogenesis of acute cholecystitis. Okay, this slide is a simplified version. Okay, the first stage in the process of acute cholecystitis is obstruction or impacted gallstone in the Hartmann's pouch. So it's obstruction. The stone obstructs the Hartmann's pouch or the cystic duct. As a result of that, the second phase is the increased intraluminal pressure. Okay, and this causes the colicky pain of biliary colic, which is visceral in nature, so associated with nausea and vomiting. Following this increased pressure, the gallbladder distends, and this distension causes some degree of edema and vascular compromise or ischemia of the wall of the gallbladder. So the gallbladder becomes distended and later becomes edematous. And this causes ischemia of the gallbladder wall, and it can progress from ischemia to gangrene and perforation. Once the wall becomes edematous and gangrenous, the pain is more localized to the right hypochondrium, and pain is more of somatic. The vomiting and nausea and vomiting become less, and the pain becomes more prominent and more tender and guarding. Okay, this is another diagram to show you the phases. First, obstruction of the cystic duct here, distension of the gallbladder, the wall becomes ischemic, and inflammation or edema of the wall sets in, and bacterial infection leading to septic cholecystitis. Okay, the phases will be biliary colic, chemical cholecystitis, septic cholecystitis, then the complications of empyema of the gallbladder, gangrene, and perforation. So these are the phases in the progress of acute cholecystitis. Clinical features of acute cholecystitis: sudden onset of right hypochondrial pain, fever, nausea, vomiting, tachycardia, tenderness and guarding over the right hypochondrium. Boa sign is an area of hyperesthesia, increased sensation between the 9th and 11th ribs posteriorly. And Murphy sign, the sudden holding of breath on deep palpation of the right hypochondrium due to the inflamed gallbladder hitting your palpating hand, and that causes pain. It stops the patient to hold his breath. The last thing here I have to mention, absence of signs in elderly patients, okay, and patients who are immunocompromised. So elderly patients and patients who are diabetics, immunocompromised, they may have minimal or no symptoms or signs. Okay. This is the pain, upper abdominal pain, more on the right side, typically in the right hypochondrium, right upper quadrant. Here, sometimes it can radiate to the retrosternal area to mimic acute myocardial infarction. Then referral pain to the right shoulder. Area of hypoesthesia, Boa sign, 9th and 11th ribs posteriorly, hyperesthesia and shoulder pain. Murphy sign, okay, with the patient, this is how you do a Murphy sign. With the patient lying supine, apply pressure in the region of the gallbladder in the right hypochondrium. Okay, I already told you the landmarks, how you locate the gallbladder. Okay, ask the patient to take a deep breath, and if he stops the inspirations suddenly, then it is positive. Okay, so the Murphy sign is positive when there is a halt in inspiration due to pain, indicating an inflamed gallbladder. Number of ways to achieve that Murphy sign. One, this is the most common way, as a lying supine, and you use your hand to palpate the right hypochondrium. Okay, or you can do this way, where the gallbladder, again, when he takes a deep breath, it hits your fingers. Or you can use your thumb, other only hands modification. But as far as you are concerned, most of the time you stick to this method of looking for Murphy sign. There's a more accurate way of eliciting the Murphy sign, known as the sonographic Murphy sign. This is achieved more accurately with an ultrasound probe. Namely, this probe is placed on the gallbladder, applied pressure is applied, and the patient is asked to inspire. Again, the same thing, patient holds his breath, then the gallbladder hits the probe of the ultrasound. So this is more accurate because you can directly visualize the gallbladder, and so the localization of the gallbladder is more accurate. Okay. What are the investigations that must be done for acute cholecystitis? Plain X-ray abdomen, I already showed you, I already talked about it. Erect and chest X-ray and abdominal X-ray. Ultrasonography of the abdomen is the main and preliminary investigation. Ultrasound, CT scan, and MRCP. Okay, these are the common things that are done, but most of the time you may be able to diagnose cholecystitis on ultrasound abdomen alone. Okay, at times you may want to do a CT scan. Very rarely you need to do MRCP unless the patient is jaundice and you suspect a bile duct blockage. Other investigations will be ECG to rule out myocardial infarction, urine analysis. Sometimes right pyelonephritis can cause urinary tract infection. Pyelonephritis also can cause severe tenderness in the right hypochondrium. And then, so urine analysis is important to check for pus cells or RBC in the urine. Blood counts, liver function, and renal function tests, followed by some specific tests like serum amylase to rule out acute pancreatitis, cardiac enzymes such as troponin T to rule out myocardial infarction. This is an ultrasound picture of a patient showing you acute biliary colic. See the gallbladder here. Gallbladder is quite normal. There is no evidence of inflammation. There's a stone here which casts a posterior shadow, which is diagnostic of a gallstone. So this is a case of biliary colic. This patient, okay, this is a gallbladder. In this case, you see the gallbladder wall is thickened. I told you the wall should be less than 3 millimeters. This is more than 3 millimeters, and there's edema in the wall, and this is known as pericholecystic fluid. And this is caused by the blockage of the stone in the Hartmann's pouch. And this is a picture called ultrasound picture of acute cholecystitis. Okay, what are the differential diagnoses of acute cholecystitis? Remember these 3 common and 3 less common. Common ones: acute appendicitis, perforated peptic ulcer, acute pancreatitis. So these are the common. Other things which can be there will be acute gastritis, acute gastroenteritis. Okay, acute gastroenteritis or AGE. Less common: acute pyelonephritis, myocardial infarction, and pneumonia of the right lower lobe of the lung. Complications of cholecystitis, which I've already mentioned before. These are the 4 complications: empyema of gallbladder, perforation of gallbladder with bile peritonitis, sepsis with septicemia, especially gram-negative septicemia, and chronic cholecystitis. Okay, this is empyema of the gallbladder, where the gallbladder becomes filled with pus, secondary bacterial infection due to obstruction, and usually the patients are very unwell and they have high fever with chills and rigors. The diagnosis can be confirmed by ultrasound with or without a CT scan. The treatment is laparoscopic cholecystectomy. Treatment of acute cholecystitis. There are 2 phases. The first phase is conservative, initial treatment, conservative, followed by cholecystectomy. Okay, the initial treatment includes keeping the patient ill by mouth, inserting a nasogastric tube to aspirate the stomach, adequate analgesia, broad spectrum antibiotics, then intravenous fluids to correct the fluid and electrolyte imbalance, as the patient may not have been feeding and may have repeated episodes of vomiting. The surgery involved is known as cholecystectomy or removal of the gallbladder, and can be done by open method or laparoscopic method. Okay, and initially it is done within the first 2 days or 3 days if the infection does not settle. If it settles, then we continue the treatment and do the operation 6 weeks later as an elective operation. So the conservative treatment first, followed by elective operation. If the conservative treatment is not successful or do not appear to be improving, the patient does not seem to be improving, then try to do the surgery within the first 2 to 3 days. Okay, now we continue with chronic cholecystitis. Chronic cholecystitis is due to repeated inflammation and mechanical irritation by the gallstones, and this is due to recurrent attacks of acute cholecystitis. Almost always the cause is gallstones. As a result of these repeated attacks of chronic inflammation, the gallbladder becomes shrunken, scarred, fibrotic, and thickened wall. And at times it can become calcified, and if the whole gallbladder is calcified, then the gallbladder is known as porcelain gallbladder. This extensive fibrosis lead to adhesions to the surrounding organs adjacent to the gallbladder, namely the liver and the duodenum. The clinical features of chronic cholecystitis include chronic recurrent right hypochondrial pain, nausea and vomiting, abdominal fullness, especially precipitated by fatty food, chronic flatulence, dyspepsia, belching, and heartburn. And in these patients, the Murphy sign may be positive, depending on the nature of the gallbladder. Okay, what are the complications of chronic cholecystitis? The two common complications are Bovaret syndrome and gallstone ileus. Now, look at this picture. Look at this picture. This is the gallbladder with chronic cholecystitis, and this is the duodenum. The gallbladder, the fundus in the body, lies on the first part of the duodenum. So in chronic cholecystitis, when the wall is chronically inflamed, dense adhesion develops between the wall of the gallbladder and the duodenum. Okay, these arrows here, it shows the adhesions. And stones from the gallbladder, due to pressure necrosis, creates a fistula between the gallbladder and the duodenum. This is the first part of the duodenum. As a result, a cholecystoduodenal fistula forms, okay, through which stones from the gallbladder pass into the duodenum. And once the stones are in the duodenum, their size may increase and cause intestinal obstruction. It can cause duodenal obstruction, okay, with gastric outlet obstruction, duodenal obstruction leading to gastric outlet obstruction, and patient presents with profuse vomiting. Okay, that is the gastric outlet obstruction, which is known as Bovaret syndrome. More commonly, this stone passes downwards through the small intestine and reaches the narrowest part of the small intestine, that is the ileocolic or ileocecal junction. Okay, and then it gets impacted in that area, causing small bowel obstruction, and this is known as gallstone ileus. This is another complication of chronic cholecystitis known as Miri syndrome. Miri syndrome, due to the chronic inflammation of the gallbladder in chronic cholecystitis, the stone gets impacted in the neck or the cystic duct, and this, because of the chronic fibrosis and adhesions around the common hepatic duct, stone causes pressure and blockage of the common hepatic duct. So the extrinsic pressure and obstruction of the common hepatic duct, leading to obstructive jaundice. So obstructive jaundice due to an impacted stone in the neck or cystic duct causing obstruction of the common hepatic duct is known as Mersey syndrome. And Mersey syndrome is usually diagnosed by MRCP and is usually managed by laparoscopic cholecystectomy. Treatment of cholecystitis, chronic cholecystitis, is basically surgery. Okay, and the surgery is two types: laparoscopic cholecystectomy, which is the treatment of choice, or open cholecystectomy through the coccus or right hypochondral incision. Conservative treatment has been tried by chemical dissolution of the stone using quinodeoxycholic acid or ursodeoxycholic acid. But this has been tried in elderly patients who are not fit for surgery and is found to be not very effective. Lithotripsy too is not done due to poor success rate and recurrence. Okay, next we come to bile duct stones or choledocholithiasis. In bile duct stones, the stones can be either primary or secondary stones. Primary, the stone forms within the bile duct itself, and secondary, it comes from the gallbladder. So look at this picture here. This is the gallbladder with the stone, and this is the bile duct, common hepatic and common bile ducts. Okay, these stones here can form de novo or primarily in the bile ducts, such as pigment stones, which accounts for about 10% of cases, but the vast majority, 90% or so, the stones migrate from the gallbladder and get embedded in the bile ducts. And the presentation of this symptom obstruction of this bile duct is classically is a Charcot striate, which consists of pain, jaundice and fever. The jaundice is the obstructive type due to obstruction to outflow of bile and stasis and secondary infection of the obstructed duct, cholangitis. Okay, this is known as cholangitis or ascending cholangitis. Sometimes there can be additional features as well, hypotension and mental symptoms. Okay, which is known as renal sphincter. Okay, this is a diagram to show you the biliary tract and the gallbladder. The stones from here migrate and get obstructed here, causing obstruction and subsequent stasis and infection. Okay, it is a acute ascending cholangitis. It's a clinical syndrome which is characterized by Charcot striate, fever, abdominal pain and jaundice that develops as a result of stasis and infection of obstructed biliary tract. In more severe cases, patients develop the renal sphincter such as fever, abdominal pain, jaundice, together with confusion and hypotension. Okay, and this bacterial infection of the biliary tract must be treated immediately with broad spectrum antibiotics and biliary drainage such as Ercp and procedure. Part 4. Gallbladder and bile ducts, diseases of the bile ducts and cholecystectomy. Okay, we talk of the other conditions, other diseases of the bile ducts. Next is your bile duct stricture. Okay, it can be intrahepatic or extrahepatic. Okay, these are strictures. It's an abnormal narrowing of the bile duct, either intrahepatic or extrahepatic. And these strictures can be either malignant or benign. Okay. So benign strictures, most of the common cause is due to a passage of gallstone. Other causes are post-cholecystectomy, injury to the bile ducts, infection, post-infection of the bile ducts, which is post-cholangitis, and today becoming common is Ercp manipulations such as sphincterectomy and stenting. Other less common causes are foreign bodies such as stents or parasites causing obstruction and inflammation of the bile ducts, inflammatory conditions like sclerosing cholangitis, and congenital cases such as Caroli's disease, biliary atresia, and choledochosis. Among the malignant conditions, strictures can be either intrinsic obstruction or an extrinsic obstruction. Intrinsic obstruction is due to bile duct cancers, and the two common ones are the Cholangiocarcinoma and the ampullary carcinoma. Extrinsic compression of the bile ducts by neoplasms in adjacent organs such as the gallbladder cancers, pancreatic cancers, and liver cancers. Among these, the most common is your bile duct pancreatic cancers involving the head of the pancreas. Next we come to gallbladder polyps. Polyps is a small abnormal growth of tissues or mucosa lining the gallbladder. It has a stalk protruding from the mucosa. It is a common condition, but 95% or more are usually benign, and rarely they become cancerous. The most important problem with polyp is chance or the potential of it to become malignant later. And in this respect, the size is a very important determining condition. Polyps less than 10 millimeters are typically benign and rarely become malignant. Polyps more than 10 millimeters in diameter have a greater likelihood of becoming malignant. Therefore, patients with polyps bigger than 10 millimeters, there is a role for prophylactic cholecystectomy. This is an ultrasound of the gallbladder. It shows 3 lesions within the lumen, and these are polyps. You can differentiate them from gallstones because they do not cast a posterior shadow. Okay, so these are 3 polyps in the gallbladder. In this patient, removal of the gallbladder was done, and these are the polyps within the gallbladder. Okay, treatment of gallbladder or symptoms of gallbladder, most of them are asymptomatic. Sometimes they become symptoms, they develop symptoms like gallstone disease, obviously pain and tenderness, nausea, vomiting. Treatment, basically there's no treatment. As long as they are less than 1 centimeter, no treatment. Just regular follow-up to check on the size, see whether the polyp is growing in size. If not, you leave them alone. If the polyps increase in size to more than 1 centimeter, then a laparoscopic cholecystectomy is advised. Next, gallbladder cancer. Gallbladder cancers are very rare, usually affects elderly women above 60 years of age, and the presentation similar to gallstones. That means chronic pain in the hypochondria. And its diagnosis is usually by ultrasound, and in this case, usually a CT scan is also needed. Most of the patients present in advanced disease where surgical resection is only possible in 10% of patients. Prognosis is poor, median survival approximately 6 months. Okay, Most of the time when they present, they already have intra-abdominal or peritoneal metastases as seen in this patient, or mental metastasis. So the role of prophylactic cholecystectomy becomes important, especially for any gallbladder polyp more than 1 centimeter diameter. Next we come to Cholangiocarcinoma, which is also known as bile duct cancer. It's an adenocarcinoma rising from the mucosa of the bile ducts. Symptoms of cholangiocarcinoma may include obstructive jaundice with abdominal pain, weight loss, and generalized itching and fever. Okay. There are two types, intrahepatic and extrahepatic. Okay. Intrahepatic accounts for around 10 to 20% of cases. The distal bile ducts, common bile duct, account for another 30%, and the remaining 60% usually involve the hilum at the junction of the right and left hepatic ducts, and these are known as Claskin tumors. Okay, and they are very uncommon malignancies involving elderly patients above 65 years of age. Most of them are adenocarcinomas. Okay, and the higher risk, there are certain conditions which are high risk for developing this cancer: fluorescing cholangitis, hepatolithiasis, hepatitis C, ascending cholangitis, choledochosis, and Carollis disease. The clinical features of cholangiocarcinoma is basically an obstructive jaundice associated with abdominal pain and early satiety and cachexia. It's a slow-growing tumor but invades locally with lymphadenopathy. Treatment, most of them are inoperable, and only 10% or so may be amenable to radical resection known as repulse operation. But this operation is a major operation, and to be done in an elderly patient with poor general condition, the prognosis is not so good. Next, we come to the last tumor. There's a Peri-Employee Carcinoma. That means carcinoma around the ampulla of water. It consists of 4 different cancers. Cancers of the ampulla of the water known as ampullary cancer, cancer of the lower common bile duct, cancer of the lower pancreatic duct, and cancer of the adjacent duodenum. Generally, the prognosis is poor in this condition. Cancer of the pancreas, head of ampulla, are different prognostic implications. Pancreatic cancers tend to have poor prognosis, whereas head of the ampulla, cancers of the ampulla of water, better prognosis. Therefore, it is important to get a tissue biopsy, and nowadays it is easily available by an endoscopic ultrasound biopsy. So once you know this is an ampulla tumor, it's not a cancer of the pancreas, then a major operation, pancreaticoduodenectomy, which is the Whipple's operation, can be attempted. Okay, this is the diagram to show you the pancreatic duct, common bile duct, the ampulla of water, and the duodenum. So any tumors arising from any of these are known as peri-employee carcinoma. And by definition, peri-employee cancer is tumor within 2 centimeters from the duodenal papilla, as shown in this diagram here. Okay, so this is the peri-employee carcinoma, 2 centimeters from here. Next we come to Govacius Law. Okay, read carefully the words highlighted in blue. The law states, in the presence of obstructive jaundice, the palpable gallbladder is usually not due to gallstone obstruction of the bile duct. It is most probably due to carcinoma ahead of pancreas, Peri-Employee Carcinoma, or Cholangiocarcinoma. Why is this so? Because the gallbladder is usually fibrotic and contracted in chronic cholecystitis with stones and is not capable of distending to be palpable. So here, this is the gallbladder, globular mass in the right upper quadrant here. So if in this patient whose jaundice, gallbladder is palpable, then the most probably cause must be either one of these, unlikely due to gallstone obstruction. Although this is generally true, but there are and can be exceptions. Okay, next we come to the most important operation, one of the most important operations in surgery, cholecystectomy. Okay, or the removal of gallbladder and the cystic duct. What are the indications? Two common indications are acute and chronic cholecystitis, or their complications, empyema or perforation of the gallbladder. Carcinoma of the gallbladder and porcelain gallbladder are also indications, but they are less common. What about asymptomatic gallstones? Okay, patient has gallstone but does not have any symptoms. So in these patients, generally surgery is not advised unless the patient is a diabetic or there are polyps with stone. Okay, so if there's gallstones with polyps, then it is an indication. Or if the patient is diabetic. Why is diabetic patients indicated for prophylactic cholecystectomy in gallstone disease? Is because if the patient develops complications in diabetes, these complications tend to be more severe. Cholecystectomy, there are two types of cholecystectomy. The classical is the open cholecystectomy through a right subcostal incision. Then you locate the gallbladder and you go for the Kellogg triangle, identify the cystic artery and cystic duct, transect them and remove the gallbladder. Nowadays we tend to go for minimally invasive surgery, the laparoscopic cholecystectomy, the operation is done through pots, 4 pots, small puncture holes. Okay, so the minimally invasive procedure is generally less painful, less infection, less complication, and faster recovery. The only setback is its cost. It's much more costly than the open method. Okay, I take you through the steps of the cholecystectomy laparoscopic. First, enter the abdominal cavity, look for the gallbladder. See, it's angry looking, it is acutely inflamed gallbladder. The second phase is the dissection of the cystic duct. Cystic duct dissected. And the third step is application of clips, okay, over the cystic ducts. Once these clips are applied, then the cystic duct is transected. Okay, the cystic duct is transected between the clips. Okay, once the cystic duct has been transected, then you identify the cystic artery and do the same. Apply clips and cut off or transect the cystic artery. So once you have done that, the gallbladder is free now. It is just adherent to the bed in the liver. So this then by cautery, this is removed the gallbladder is removed through the small hole. Next we come to the complications of cholecystectomy. Okay, the first three listed are the common complications: post-op bleeding, immediate and delayed, post-operative infection, the area of the operation, and also the wound infection, cholangitis, abscess formation, especially localized abscess around the pancreatic gallbladder bed, and liver abscess. And this can lead to septicemia. Bile duct injury during the process of cholecystectomy, especially in patients with chronic cholecystitis with extensive fibrosis and adhesions, bile leakage, and bile duct strictures. Others include retained stone, obstructive jaundice, and acute pancreatitis. The other important complication which occurs quite commonly after cholecystectomy is what we call post-cholecystectomy syndrome. Okay, this is the persistence of the symptoms which are similar to before the operation. Okay, so the symptoms persist after the cholecystectomy, so they are known as post-cholecystectomy syndrome. They usually dyspepsia, vague pain in the right hypochondrium, belching, and the patient feeling very uncomfortable after heavy meal. Okay, and a number of causes have been implicated in these vague symptoms, such as minor bile leaks, retained stone, and papillitis are some of the causes that they have postulated. Okay, thank you for joining me during this talk on gallbladder and bile ducts. I hope you found it interesting and useful, and I hope to see you again in another lecture. Thank you for joining me today. Before I end, I would like to go through this slide in a more lighter note. Okay, here, as you're all aspiring to become doctors, young doctors in a few years' time, and the most important is your doctor-patient relationship. Your attitude towards treating patients is very important, and this attitude must start now, and it must be developed over the next few years. Okay, so what are the things that you must have? You must understand is the patient is not an isolated arm or a leg. Okay, the patient is not a robot, a mannequin here lying down without feelings. A patient is one who has got emotions and feelings. So you must treat the patient as a whole. Okay, just not his limbs, not just his heart, not just his abdomen or the head, but the whole body and mind of the patient. Okay, his emotions and feelings. Okay, again another picture here to show you the patient is a very complex structure, not just a robot, but with emotions and feelings. Okay, which affect the healing process of your treatment. What the patient needs from you is empathy. Remember, not sympathy. Empathy means you must feel for the patient. Put yourself in the patient's place and feel for him or her. Okay. And in this process, I find these 3 C's are very important. These are important empathetic characters that you must develop from the beginning at an early stage. The 3 C's is caring, sense of concern and for the patient, and also an attitude of compassionate towards him or her. Okay, so with these 3 C's, we should combine to give you the empathy, person who is empathetic, then your doctor-patient relationship will be in the right path, and you will find that the patients will recover faster to your satisfaction.